Welcome to my presentation on ureteral stones. The title of the conference is Stuck Between a Rock and a Hard Place. And the reason I use this title is because I find that a lot of times we don't have a whole lot of information on what to do with ureteral stones. So there's a lot of information out there on kidney stones, on nephroliths, and what to do with cystoliths or bladder stones and urethral stones. But there's very little information on what is the best approach for patients with ureteral stones. And so I'll start by presenting a kitty cat that I saw. Her name's Paloma. She's a 12-year-old female spayed domestic short hair, and she was diagnosed as having chronic renal failure a year ago. On abdominal palpation, she had some irregular kidneys, and she was diagnosed with IRIS stage 2 renal failure. Her urea was 18, her creatinine 180, and her phosphorus was 1.3. A urinalysis revealed a low specific gravity of 1025 with a negative urine culture. Her blood pressure was fine, and her urine protein to creatinine ratio was 0.1. She was then placed on a renal diet, and she was followed up 6 months later. Her azotemia and phosphorus were unchanged, and she was considered on her renal diet until she represented with a 2-week history of decreased appetite, lethargy, and weight loss. On physical exam, she was dehydrated, her kidneys were small and firm, and her chemistry panel revealed much worsened azotemia with a specific gravity of 1027. So the diagnosis we had for her was decompensated renal failure. Some of the differential diagnoses that we had were either progression of chronic kidney disease, possible pyelonephritis, some current systemic disease that might be making her ill, and she became dehydrated. Other thing than possible is a renal obstruction, a post-renal obstruction. So our plan was to do a complete urinalysis, which we did, and was unremarkable. Her culture was negative, pretty much ruling out pyelonephritis. Her blood pressure was fine, her thyroid level was fine, and then we went ahead and did some abdominal radiographs. What we found on abdominal radiographs is she had a small left kidney. Her right kidney was kind of on the smallish side too, and we also saw multiple ureteral calculi, which you can appreciate on these rads. Abdominal ultrasound revealed a small left kidney with some parenchymal loss of architecture, chronic kidney disease, marked hydronephrosis of the right kidney with marked hydroureter, which is the image I have on the screen. And so given those findings, what we were highly suspecting, obviously, was a ureteral stone causing obstruction. And so just to talk a little bit about ureteral stones in cats, is it is definitely an important cause of chronic and acute renal disease. And a lot of times, I think when these cats come in, the differentials that we have are decompensated kidney failure and pyelonephritis, but sometimes we forget that a lot of these cats with chronic renal failure actually do develop stones also. And so having chronic kidney disease actually puts cats at risk of developing kidney stones also, and ureteral stones. Most of the ureteral stones that we see in cats are calcium oxalates. And stones can form around debris, blood clots, pus, or they can come down from the kidney and block the ureter also. Occasionally we'll see cats, whereas on abdominal radiographs they have ureteral stones, and yet they aren't obstructed, and they're more of a fortuitous finding. Obviously, some of the complications of having ureteral stones, most common complication is obstruction, but I have had some cases, especially in dogs, present with just chronic hematuria and recurrent infections that were not obstructed. If we look at diagnostic imaging, radiographs have a sensitivity about 81%, and ultrasound has sensitivity about 77% in detecting stones. Now, these were older studies. However, I think the take-home message is that ultrasound can occasionally miss ureteral stones, especially if they're not obstructive. So if you have a cat with a 2-millimeter stone in the mid-ureter surrounded by bowel and is not obstructed, that stone is going to be really, really hard to see. And so a lot of times I prefer performing radiographs, since most of the ureteral stones are calcium oxalates. They show up quite well on radiographs, and I prefer using radiographs to screen patients for stones. And if they do have stones, then certainly ultrasound is very, very useful in detecting whether these stones are obstructive or not. So let's talk a little bit about ureteral obstruction. We definitely know that complete ureteral obstruction is not a good thing. It results in nephron loss by markedly reducing glomerular filtration rate, which I'll refer to as GFR. The damage can be completely reversible if patency is restored within 7 days. And we have that information basically from studies that were done in beagles in which healthy beagles that had their ureters ligated and then went in and removed the sutures from those healthy beagle ureters. And so when I read studies, obviously, that are using healthy animals in an experimental context, we always have to be very careful about extrapolating that information to our clinical cases, especially the fact that most of our clinical cases come in with chronic renal disease, and so they may not respond the same way as a healthy animal would to ureteral obstruction. But it does give us a little bit of an idea of how much our nephrons can recover and in what period of time will this recovery occur. And so to go back to the study in healthy beagles, beagles that had their ureters completely ligated, as long as within 7 days the obstruction was relieved, then they actually had to return to normal function. So we do feel that if obstruction is less than 7 days, there's a good chance that the nephrons will recover and become functional. After 2 weeks, however, there's about 50-50 chance. So there's about 50% of the nephrons that are lost will be lost forever. And after about 4 weeks, we do get irreversible nephron loss. I guess, again, the take-home message for me from this study is that ureteral obstruction is an emergency. And the sooner we address the ureteral obstruction, then the better recuperation of nephrons we may have and potentially have a better outcome. So that the way I treat ureteral obstructions is on an emergency basis, not as an acute emergency, such as a GDV or a septic abdomen. However, I don't like to have these cases waiting 3, 4, 5, 6 days. I prefer to see them within a day or two, because every day or every couple of days that we're leaving an animal obstructed could, again, cause irreversible nephron loss. And so the quicker we address these cases, I think the better chance we have of having preserving some nephron function.